Okay, this is Amanda Williams, and I'm doing a case study on peptic acid disease. So here's my patient. I have Tom, who is a 48-year-old male, coming into the office today with really, really bad heartburn, as he says, wicked bad heartburn. He's a lobster man who works long hours on his fishing boat. States that his heartburn is waking him up every night, so he's not sleeping well, which makes for lots of trouble when he's trying to stay awake for his long days on the boat. Reports that he's been taking omeprazole, 40 milligrams over the counter daily, and only helping a little bit with his heartburn. He has read that on the internet there are some antibiotics that might help with his issues. Also that he does not want to go to a specialist because they're too expensive and he has a really high deductible. So that is not an option for him. Okay, and moving on to his history, patient's past medical history is hypertension, peptic acid disease, and also chronic neck and back pain from his long days and overuse of his body on the water as a lobsterman. Current medications is lisinopril 20 milligrams daily, omeprazole 40 milligrams daily, tramadol as needed 50 milligrams every 4 to 6 hours for his back and neck pain. Also is reports that he's taking ibuprofen occasionally for breakthrough pain when his tramadol isn't helping. He has no known allergies to any drugs or any other allergies in general. For social history, he reports that he is married, lives with his wife Susan and his dog Charlie, has one son Tom, who is 19 and is away at college. Reports that he's a non-smoker, but does, after a little while in the visit, admit to having the occasional cigarette when he's super stressed out on the water, hanging around with his buddies on his fishing boat. Does not use any smokeless tobacco products like chew. Also reports that he drinks a decent amount of alcohol per day. Reports drinking 2 to 4 beers out on his boat daily. His diet is pretty poor. He eats usually fast food during the work week because he's pretty busy. Works long hours, so he grabs food in the morning before work and grabs fast food on the way home. Does eat at home. His wife Susan cooks at home for him on the weekend, cooks large meals, usually a lot of meat and potato type things. A lot of meal high in protein. Family history, his mother is alive, has CAD and hypertension. She's 70. His father passed away at age 60 from an MI. Brother passed away at age 43 from bladder cancer and complications. He was a smoker. And he has another brother who is 38 and alive and well. Then there's review of systems. Pretty much overall benign. General reports that he is in a good mood, although chronically tired because he is waking up constantly at night because of his acid reflux and epigastric pain. Overall, no real other issues, no neuro issues, no HEENT issues, although he does have the epigastric pain, as he previously reported at night. And other notes is that he also reports GI issues, which is the same. Epigastric pain, burning, especially at night, reports at a 5 out of 10 when it's at its worst, especially after a big meal and when he's going to bed. Does report some occasional loose stools and diarrhea and some intermittent nausea with no known cause. And also, as previously reported, he is taking the omeprazole with little effect on his epigastric pain. Going through the rest of his systems, no other problems of note. Upon physical exam, his vital signs are within normal limits. His blood pressure is good at 126/84. Temp, pulse, and respirations and O2 sats are good. Height and weight are in a good range, although his BMI is a little high. He is ranked as overweight. As far as his overall physical exam, mostly benign. General, he's a pleasant, cooperative male, dressed appropriately for the weather, needs no assistance getting onto the exam table, is alert and over 2 times 4. As far as his HEANT, his head is normal cephalic. Pupil is equal and reactive to light. Sinuses are non-tender. His ears look great. His oral mucosa and nasal mucosa are fine. No lesions are bleeding. His teeth are in good repair. Trachea is midline. No masses to his thyroid. No bruits. No JVD or no adenopathy. Respiratory, his lung sounds are clear. No extra sounds. Cardiovascular wise, no murmurs, gallops, or rubs. He has a regular heart rhythm, S1, S2. GI, he has a soft, rounded, non-tender abdomen, hyperactive bowel sounds, no organomegaly. GU, also within normal limits, normal male genitalia, no lesions or discharge, or pain or tenderness. Peripheral vascular, also within normal limits, and musculoskeletal and integumentary as well. And moving on, some kind of tidbits, first of all, about peptic acid disease. It occurs from either oversecretion of the acid, and also which damages the GI tract lining from the exposure to the acid, which then can lead to ulcers. These ulcers can be in the esophagus, stomach, or duodenum. Peptic acid disorders play a large part in a patient's quality of life and is a huge problem in primary care. And as you can see, it costs a lot of money per year treating that disorder. And approximately 40% of adults in the US complain of either monthly, weekly, or daily heartburn. So a large percentage of people complain of heartburn on a regular basis. And also, as far as treatments general for peptic acid disease, they include medications to control the release of stomach acid to minimize the symptoms of the epigastric pain and burning, and also help to try and treat and also prevent ulcers of the GI tract from forming. Okay, and moving on to a little quick patho of the digestive system and also the peptic acid disease overall. Digestion begins in the buccal cavity when you put a food bolus in your mouth and you start to chew that food bolus. During the chewing or the mastication, the salivary glands and stomach are releasing enzymes to help break down that food. The parietal cells, which are found in the stomach lining, the epithelial layer of the stomach lining, and they have little rugae, kind of the undulated peaks and valleys, as you can see over here on the right. The little kind of top layer there, they're known as pits and glands. They are the specialized cells which secrete the stomach acid or the hydrochloric acid, and also they secrete intrinsic factor. The intrinsic factor is required for the body to absorb the vitamin B12, and also it's known that the damage to the intrinsic factor secreting cells, which are those parietal cells, can hinder B12 absorption, which can lead to several types of anemias as well, just as a side note. And then we have the chief cells, which are in the mucosal lining of the stomach, and these cells release the digestive enzymes pepsinogen and gastric lipase. And also the hydrochloric acid and enzymes released by the stomach create an acidic atmosphere needed to digest the food, and as well kill any bacteria that may be lingering in the food. However, this acidic environment can definitely kill some of the good bacteria living in the gut if the environment becomes too acidic. And then we also have histamine, which is another component that's released in the stomach, and that helps stimulate the acid release in the stomach as well. Okay, so then kind of go over quickly the regulation of acid secretion. Okay, so a general little overview of the regulation of the acid secretion in the stomach. The release of acid by the parietal cells is overall controlled by the CNS, PNS, and also eating. As we talked about, once you have a food bolus in your mouth, the acids start to be secreted by your body. So acetylcholine and histamine stimulate the parietal cells to release these stomach acids. And as well, gastrin is produced after the food is ingested, and this gastrin stimulates the release of acids by stimulating the histamine that we talked about in the previous slide. And the more you eat, when you eat a meal with higher protein, more gastrin is released in order to help break down that food bolus. So if you're eating a meal super high in protein, you're going to have more gastrin released, which will then in turn stimulate more acid to be released. And gastrin is normally inhibited by a low pH, a more acidic environment. And so if that mechanism gets damaged, then you'll have more gastrin release even though your pH is low, and more acid then, causing your stomach to be more acidic. The somatostatin is also the mechanism to inhibit acid release as well when the pH is too low, to help prevent as well the pH from becoming too low and too acidic in the stomach. And on the next slide here, we have just a little quick overview of that. You can see here the somatostatin, as we talked about just recently, is the kind of inhibitory mechanism to inhibit the, the gastrin and the histamine from releasing more acid into the stomach. You can see that the gastrin release then in turn causes the histamine to release and causes the parietal cell to be releasing hydrochloric acid, or the stomach acid, and the acetylcholine as well, acting on the parietal cell to release hydrochloric acid as well. Okay, and then we move into medications for treatment. First group is the histamine blockers, and I picked just one common histamine blocker, which is famotidine. Mechanism for famotidine is that it blocks the H2 receptor on the parietal cell, which then prevents gastric acid from being released. It is metabolized mainly in the liver, and unsure about P450 enzyme metabolism. Common dosing for famotidine is 20 to 40 milligrams twice a day for GERD, and then 40 milligrams in the evening for ulcer treatment. As far as monitoring for this medication, you should obtain a baseline creatinine level and then monitor periodically, especially if using long-term. And a little tidbits on famotidine: it's most effective if you're taking it at nighttime. So ensure if you have a patient taking this med that they're taking it at the appropriate time of day. Common reactions: headache, dizziness, constipation, diarrhea, changes in taste, and also the B12 deficiency with long-term use, as we talked about in the beginning of the slides. Adverse reactions: angioedema, agranulocytosis, thrombocytopenia, seizures, and then some cardiac arrhythmias as well. Of note, the H2 receptors that this med acts on are on smooth muscle and also cardiac muscle, so that's why you can get some heart arrhythmias with this medicine. And then as far as lactation and pregnancy, it's a pregnancy category B, may be acceptable, but still seems like it's a little unsure. And then also for lactation, do not use during lactation as it can pass into the breast milk. As far as cost, this medicine is available over the counter and is cheap. It's on the $4 Walmart list for a 1-month supply according to the GoodRx app. Okay, and then I have a little table here of some other histamine H2 blockers. Some other common ones you may see, like cimetidine, ranitidine. Then nizatidine I've never really heard of. That doesn't sound a common one to me, but the other top ones are pretty common. So we have the standard dosing, available strengths, and then kind of the time of action and their urinary excretion. Just a quick little tidbit on that. And then we move on to proton pump inhibitors. I chose omeprazole, which is a common one, and also the med that Tom is on. The mechanism of action for omeprazole is that it binds to the hydrogen potassium proton pump to inhibit the gastric acid secretion by those parietal cells. And it is metabolized in the liver by P450 enzymes. Common dosing for omeprazole is 20 milligrams in the daily before meals, and then 20 to 40 milligrams daily for ulcers treatment. And also of note, you should use lower doses for hepatic impaired patients. So as far as omeprazole, it can help to reduce the risk of ulcers in patients, especially patients who use NSAIDs, but does not help prevent ulcers. Also, this med, in contrary to the H2 blocker, is most effective with taking in the morning before breakfast. Should be taken every day and not as a PRN, because it is best more effective as it builds up into the body, so more effective after a few days of use. And should be taken on an empty stomach before breakfast. However, this med should not be used for long-term use. Recommended duration is 4 to 8 weeks. Monitoring labs for this medication could be a magnesium level at baseline, and especially if you're using long-term, you want to check the magnesium levels. Common reactions is abdominal pain, nausea, vomiting, headache, increased gas, and B12 deficiency as well in long-term use. Adverse reactions include C. diff-associated diarrhea, pancreatitis, fractures, as related to osteoporosis with long-term use, hypomagnesemia, lupus, and renal and hepatic impairment. As far as lactation and pregnancy, this should not be used. In pregnancy, it's a category C and can be a possible teratogen, and I could not really find any data on use in lactation. So I would advise on not using it. This med is also relatively cheap. It's available over the counter and is also available at Sam's Club for $4 or $10 at Hannaford, both for a 1-month supply, according to GoodRx. And then I have a little list of the other common PPIs, which include pantoprazole, lisinoprazole, esomeprazole, and a few others, and also have the common dosages, the excretion, the metabolism, and all that sort of thing. Quick little reference here for that. And then also for other treatments, there's mucosal protective agents. There's a variety of antacids like sodium bicarb, Tums, milk of mag, aluminum hydroxide, which help neutralize the stomach acids and inhibit pepsin. They can be taken before or during a meal to prevent symptoms, but the relief is fairly short-lived, so it's kind of used as a PRN, not a constant use. Used mainly for mild GERD. And as well, they're not currently prescribed for treating ulcers, usually just for mild intermittent GERD symptoms. And also of note, bismuth salicylate can be used to prevent or suppress bacterial growth, and is also of H. pylori, and is usually a combo therapy in addition to antibiotics for H. pylori treatment. And as far as antacids in renal patients, Tums are the preferred choice for those patients. All those above are available over the counter and are relatively cheap and easy to access. Some adverse effects from the above meds would be ingesting in large amounts, so hypercalcemia, there's a lot of calcium in most of those antacids, renal issues, and metabolic acidosis. They could also alter the absorption, elimination of other meds by changing the stomach and urinary pH if taken in large doses. The magnesium preps can cause diarrhea and hypomagnesemia if taken in large doses, and also the aluminum preps can cause encephalopathy and osteomalacia in the renal patients. So caution in those patient populations with those meds. Okay, and then one other thing I want to talk about was H. pylori, which is a common bacteria that can be found in the gut in over, I believe, 50% of the population. But if a patient is chronically colonized, this infection can lead to cellular changes, ulcers, and even cancers. H. pylori is transmitted fecal-oral or oral-oral. And so one thing I was thinking about with Tom is that I would test him probably for H. pylori. There are several methods of easy testing to see if he has H. pylori colonized in his gut, which may be contributing, I was thinking, to his GERD symptoms. So there are 3 different tests I was thinking about for him. One is the breath test, or the SIBO test, which measures hydrogen and methane in the breath that's released by the invasive bacteria, the H. pylori in the gut. As far as price, I couldn't really find a good price range, but it seems like it's pretty expensive. One website I found said it would be approximately $450 for the result to take the test, and the results could take up to 2 weeks. There are some kits that look like you could order them online and do them at home, but I would question the reliability of the test, because usually when you do a SIBO test, you have to be off your PPIs and no other type of antacids or any medications for 2 weeks. So I would question that a patient would do that reliably at home without the advice of a healthcare professional. Also, the sensitivity and specificity of that test is pretty low, so your results may not be very accurate. Another test would be the blood test, the H. pylori antigen test. Has a high specificity and sensitivity of around 90% or so, and is also useful in diagnosis of new cases. Pretty commonly used by providers, but less accurate than the stool test, which I'll talk about next. The stool antigen testing is more specific at 98% and sensitive at 94%, so relatively reliable test, and probably the one I will choose for Tom. It's good for diagnosing and also for following up post-treatment. So after your patient with H. pylori has been treated with antibiotics, you can follow up and see if that infection has been eradicated. As far as prices go, they varied online, but I found that some stool kits that you can order online that can be sent to your door, so you can do the test in the privacy of your own home for around $100. So I was thinking that might be a good option for Tom, since he has a high deductible and it's something he could easily do at home and send back. And the main reason I was thinking about maybe an H. pylori infection for Tom is that he was having some nausea, vomiting, and also the abdominal pain, epigastric pain, and diarrhea as well. So I was thinking maybe if he's having a lot of this epigastric pain, which is not being treated with the PPIs, something else may be going on. And I would see if he would be up for doing the stool antigen testing. Okay, so my plan for Tom is that if he is agreeable to doing the H. pylori test, the fecal antigen test, and it comes back positive, I would treat him per the Stanford guide, which guides us to use omeprazole 20 milligrams BID for 10 days, and also amoxicillin 1 gram twice a day for 5 days, and then a chlorithro and tinidazole combo for the remaining 5 days. Also, they mentioned that you can use a bismuth prep like Pepto-Bismol for 10 days as well for a combo therapy. And if he is not agreeable to the testing, or the testing comes back negative, I'd probably recommend a few different things. First, I would recommend that he takes 20 milligrams BID instead of his 40 milligrams daily. So he's taking a dose before breakfast and dinner, and then making sure also he's taking his breakfast dose on an empty stomach to help the efficacy of that dose. Also, I would ensure that he's taking the omeprazole daily and not kind of as needed, as it takes a few days to become effective and build up in his system. And also, I found some guidelines on Hippocrates, the 2013 ACG guidelines for treatment of GERD symptoms, and also found that he could add an H2 blocker like famotidine, 20 milligrams daily, to his omeprazole to help with his GERD if the PPI is not helping. And if all those measures fail, I would then maybe trial a different PPI or consider a GI consult. Maybe there's something else going on. He may need a scope to see if there is an ulcer or something else contributing to his symptoms. Okay, and then I'm going on to patient education. So first off, I would tell him to stop taking NSAIDs. Those can contribute to stomach ulcers and will not help his GERD symptoms. I would recommend that he use Tylenol sparingly if needed for his back pain. Also, educate that tramadol may increase the hypotensive risks of his lisinopril, so be careful with position changes, sitting to standing, watching for any orthostatic hypotension. And then also educate him on the importance of taking the omeprazole in the morning on an empty stomach and not PRN, and see how he does, possibly taking it twice a day. And then also there's a large list of lifestyle modifications that can help with his GERD symptoms. Definitely changing his diet, avoiding trigger foods like fast food, fried food, carbonated beverages, coffee, alcohol, citrus, acidic foods, and also encouraging a high fiber diet with fruits and vegetables. And also, I know he works long hours on the boat, but trying to encourage him not to eat dinner 2 to 3 hours before bed, no snacking before bed, and also no lying down right after he eats, as the acid can definitely be a factor right after eating. One other thing he can try is raising the head of his bed up a little bit with blocks to help reduce acid reflux, or definitely laying on his right side. A few other things is weight loss, as patients with a higher BMI have more acid reflux, and also exercise, which could decrease the occurrence of reflux. And I found one website that said it possibly could strengthen the muscles to protect against acid reflux. And last but not least, educate that smoking can contribute to his symptoms. So encourage him to not smoke even though he's an occasional smoker, and that even the occasional cigarette can be harmful to his GERD symptoms and also to his overall health. And I believe that is it for today. Here's my references, and I hope you enjoyed my show.